My name's Hugo Penny. I'm one of the clinical lecturers in gastroenterology at Sheffield, and I have the pleasure of kicking off this late morning session. And to start with is Dr Mo Thoufeeq, who's one of the consultant gastroenterologists at Sheffield, who's going to be talking about fit testing. Thanks, Mo.
Thanks, Hugo. Thank you all. Thanks to those who's listening to me online. So we've been to the north and heard about upper GI stuff. We're moving to the more fascinating lower GI. Let's move down south. So Charlie mentioned about integrated system and how we need to work together. It's a fascinating opportunity for us to work together with the primary care. So conflicts of interest, I'm a gastroenterologist. However, I'll try and sort of bring things together and talk to you almost like a Q&A type question answer. So we'll go through each slide in that way. So first things first, colorectal cancer is a big problem. You don't need me to tell you. You can just Google it. Everyone knows that. We've heard Marion mention that it was on news only this morning. So there's a lot of cancers that get detected per year. It's the second most common cancer causing death in the UK. Guess what? 54% is preventable. How is it preventable? All cancers start in a form of an adenoma carcinoma sequence. So all cancers, majority of them, start as a polyp, is what we call it as adenoma or polyps. So these take about 10 years before they become cancer. So how can you stop the sequence? You simply eradicate it. You do polypectomy in the form of a colonoscopy. So colonoscopy is a great tool. We are GPs. We are preventing cancers by getting rid of those polyps. So this is my good friend, Saj. We look alike except for the hair. He's declared war on cancer. The government has said, let's declare war on cancer. Early diagnosis, we know, improves survival and also helps with curing cancers. The NHS government has a strategic plan to say that we have to diagnose cancers in stage 1 and stage 2 at 75%. Aspirational, is it possible? That's by 2028. Where are we currently? 37%. Our 2-week weight pathways may not actually achieve this goal. We're not achieving already. There is evidence to suggest that we are not detecting cancers early and not curing them. However, we also know, this is South Yorkshire data, that's where we're sitting, we know that the screening uptake is fantastic. 70% of our patients that you send for screening take up the screening. 10% of them we detect cancers. These are majority, if not all, are completely asymptomatic. And we also detect adenomas, so as I already told you, these prevent the progression to cancer. And also, screening also helps us to detect early cancers. So 18% of the cancers detected in first stage are with the symptomatic group, whereas screening detects in 45%. It's a win-win situation. And you know this, there's a huge demand for the endoscopy, and there's a huge demand in terms of the 2-week referrals. There's a massive demand for colonoscopy, both in terms of symptomatic and the screening population. And likewise, we've grown. We've increased the capacity over 100% in some areas. Patients are queuing up to have colonoscopy. It's a great test. However, can we manage to do them all? Almost 3 million people were referred for cancer check over the last 12 months. Do we have a friend? Someone can help us to triage so that we can see which patients need a colonoscopy? Yes, we have. We have a pool test. It's called fit testing. So these will help us to triage for you to go through and have refer the patients for colonoscopy. What is a FIT's CV like? It's not new. It's been there for a long time. It's been there since 1978, where goat's antibodies were used. Goat's antibodies to hemoglobin was used, and you all know in 2017, NICE introduced the diagnostic guidance and introduced FIT into the pathway. FIT came in, replaced FOBTs, the fecal occult blood, into 2019, 8th of June. Then COVID happened, the first case. Not interestingly, you all know it was in Yorkshire. So we had a lot of experience with COVID, and COVID actually helped the screening in a way because it helps us to prioritize and made this more popular. You've all seen this. So lots of arrows and lots of markers to say, how do we actually deal with patients when they get referred, when they come to you with bowel symptoms? Clearly, as you know, in the absence of rectal bleeding or a mass, you'd want to do a FIT test. So how do you interpret that? You know this, if the FIT is positive and more than 10, you would consider a lower GI referral. Would you consider a lower GI referral, urgent 2-week wait, if they're less than 10? Yes, if they got symptoms, plus they have anemia or thrombocytosis or thrombocytopenia. If they're completely not detected, you would like to still consider referral if you're still worried and use the other pathways. So we mentioned about FIT replacing FOBTs, the fecal occult bloods. What has it done? It's improved from a statistical point of view. It's much better than FOBT. It's much better than detecting cancers. And from a patient's point of view, they just need one stool sample. Imagine telling your patients to do 2 or 3. They don't like it. They prefer just sending a 1 sample. And they don't need to alter the diet. You can have your curry, fish and chips, whatever. You don't need to change it. For an FOBT, you need to avoid eating certain food items. And it's a quantitative test, so you have a figure rather than saying positive or negative. However, there are thresholds which are different. The screening uses a different cutoff than what we use in the symptomatic, as I've just told you, and different countries use different FIT levels for the screening level. Why is that? Why don't we have an INR sort of a thing, which is internationally the normal thing? That's based on policymakers, what's available, the logistics, how many lists are available, and what sort of age groups of population that we deal with. So is FIT better than history? You guys are busy, you got 10 minutes. Do you spend 10 minutes asking his history? I think it's important, but however, we do know that FIT is much better than even a history, because I know sometimes patients do not remember their symptoms, or they forget, or they tell their family members and they've forgotten, and also there's been studies to show that patients are not good in recalling their symptoms. If you've got a negative FIT, you can literally virtually rule out colorectal cancer, although in not all cases, but majority. However, at the same time, I think symptoms are still important. We know that symptoms do matter. As you can see, that I don't know whether this points, but this doesn't point. It points here. You can see there are symptoms, and there are tests, FIT test results, which should point to you, so which are the high likelihood of having cancer. The cancer detection is much higher if the FIT is higher. I know anemia behaves slightly different. We can discuss that in question and answer sessions, but it does behave slightly differently. So you've done your symptoms, and you still need your blood test. As you can see, that having a FIT positive plus anemia and having a high platelet count increases your positive predictive value for colorectal cancer. So we do need the test to be done. However, at the same time, FIT can miss colorectal cancer. Nothing is perfect. Colonoscopy can miss cancers, CTs can miss cancers, FIT can miss cancers as well. The sensitivity is up to 90%. So in about 10%, we may be missing cancers. In particular, you can see FIT negative colorectal cancers have been reported, and you can see the high percentage in patients who've got iron deficiency. Why is that case? We don't know. It could be because they might be right-sided cancers, which may not have bled, or they bled once and they stopped bleeding, or they didn't bleed at the time when they had the FIT test done. All these are possible. This is important to take that into account when you have a negative FIT. So this is a pragmatic approach which is being shared by my good friend and colleague and collaborator from York, James Turville, who's suggested, what do we do in iron deficiency? Because the BSG does not recommend, the British Society of Gastroenterology does not recommend doing a fit test in the context of iron deficiency. So how would you do it? If you got to ask two questions. What's the age of the patient? And is the patient anemic or just iron deficient? So if they're anemic, if they are men, or if they're women over 40, if fit, you do a fit, and if it's positive, you do a 2-week wait referral. Likewise, if they're fit negative, you still want to refer them, and perhaps you assess and see, maybe you do a routine referral or do an urgent referral. You have other symptoms such as weight loss or anxieties. I think you have to look at it, but certainly they need a referral. And we're moving on towards iron deficiency. You look at what age they are. If they're more than 40, you do a fit test, and if it's positive, you do a 2-week wait referral. And if it's fit negative, you would consider whether you can manage it yourself. And then if anemia persists or iron deficiency persists, you would want to refer. In the younger population, the likelihood of having cancer is much lower in a context of iron deficiency. You may wish to manage it yourself. And if things persist, you would refer to the secondary care. And again, this is a pragmatic approach. This is what's been followed by James Turville, who's been a pioneer in FIT. So what happens? You have patients who do not comply. They've had a FIT test and they've decided they do not want to go ahead to have any more colonoscopy or tests. It is dangerous because the likelihood of them getting cancer multiplies, because you have to understand that the FIT helps us to diagnose precancerous lesions, and these precancerous lesions may actually become cancerous. So you have some of you may recognize this gentleman. He's very fit, and he's had a FIT test done via the screening program, and he's decided to go on holiday. Can you actually wait for the results? How long can he wait? He's had a FIT test, it's positive. Sorry, no, he got the results, but how long can he wait? So he can't wait too long. Most tests are done within 30 days, but the risk of colorectal cancer developing in a gentleman who is positive FIT is doubled if you still wait more than 200 days. So you really want to do it early. So if they're planning on holidays, you want to do it quite early. So we talked about, does FIT reduce the need for scopes? Yes, it does reduce the need for scopes. If you look at it, the number of scopes required to diagnose one colorectal cancer, if the FIT is more than 10, it's 6. Whereas if you compare it less than 10, that's 232. So yes, doing a FIT does help us to request and do more colonoscopies. We've talked about before, do we do 2 FIT tests or just the 1? Currently, the advice is only to do 1 FIT test because you do not want to wait for 2 tests. There might be a delay, and the evidence does not actually suggest any benefit in majority of the tests, except for a couple of tests done recently. One of them in Lancashire, which has shown that it's actually a good exclusion if you got 2 FIT negatives. What about FIT and calprotectin? Yeah, FIT is the best test for colorectal cancer, but if you use FIT and calprotectin together, it does not increase the accuracy of colorectal cancer. A negative combination may actually reduce need for colonoscopy. What about calprotectin in over 60s? We do not recommend that. You need to be doing a colonoscopy or consider a FIT test in an over 60. And the issue is about rectal bleeding. Would you do FIT tests in a context of rectal bleeding? It's best not to do it. However, if you've done it, we don't always notice it's positive. It sometimes is not detected in the tests. We also know that patients who've had FIT test positive and they have rectal bleeding, only about a very small percentage end up having colorectal cancer. Because there could be a lot of them actually have early lesions such as polyps or hemorrhoids or have diverticulosis or have vascular lesions or may actually have colitis skip this. This is Imran, who's done a colonoscopy. FIT test was positive, and he's reassuring the patient, although you can see that the patient looks quite ill. So, what about upper GI cancer? The likelihood of having an upper GI cancer in a positive FIT is almost close to zero, because the globulin gets digested before it comes to the colon. But, however, there's still a high percentage of there's still about a 1% likelihood of having other cancers, particularly the upper GI cancer, if the FIT is positive and the colonoscopy is negative. This, you would only do an upper GI investigation if the patient is anemic or has other symptoms. So this is my final slide. Question is the patient fit for a FIT test? We know we're doing FIT tests to diagnose colorectal cancer. That's either through your CT scan route or colonoscopy route. And we would aim for patients to have a surgical intervention, hopefully cure them of the cancer. However, each of these, except for a FIT test, has its risks, including risk of mortality. Having a negative FIT test is fantastic, but having a positive FIT test, and if the patient is not really fit for a colonoscopy or a CT, you would like to think there is an ethical dilemma. Should we do the FIT in the first place at all? On that note, ladies and gentlemen, I'll finish my talk. Thank you.